Yeah, good morning, everyone. So we'll start the day with physiology and physics of pressure monitoring. Now, my entire concentration will be on the invasive arterial BP monitoring and the physics related to that. Now, why IABP? Because it provides continuous beat-to-beat pressure measurement. Waveforms can analyze and give us further information. It is useful where it is difficult to have a NIBP measurement. It reduces the risk of tissue injury and neuropraxia. Frequent arterial blood sampling is made easy, and it provides increased accuracy in critical conditions. Now, the salients that I'll be covering the topic will be the components of the arterial waveforms, is physiological correlations, its clinical application, and something to do with the physical principles that will cover the transducer functioning, basically the Wheatstone bridge principle, natural frequency resonance, and something about damping and coefficient. Now, what are the information in a nutshell derived from an arterial waveform? Now, from the measurement itself, we can get the heart rate, systolic BP, diastolic pressure, that tells about the coronary filling, mean arterial pressure, that tells you about the systemic perfusion, pulse pressure, changes in the amplitude tells you about the pulse pressure by the pulse pressure variation, and also from the waveform shape, we can get various information like the slope of the anacrotic limb, slurred wave in aortic stenosis, pulses bispherians, paradoxes. Okay. So, what is an arterial pressure wave? Now, arterial pressure wave is a pressure wave that travels much faster than the actual blood which is ejected. It represents the impulse of the left ventricular contraction conducted through the aortic valve and the vessels along a fluid column of blood up to a catheter, up to another fluid level, that is the heart tubing, and finally into your Wheatstone bridge transducer. Okay. Now, the arterial pulse wave, what are the major components of it? It has a systolic phase, which represents a rapid increase in the pressure to a peak, followed by a rapid decline. Now, this phase begins with the opening of the aortic valve and corresponds to the left ventricular ejection. Okay. There is a diacritic notch that represents the closure of the aortic valve, and followed by a phase, diastolic phase, which represents the runoff of the blood into the peripheral circulation. Now, there is a peak which correlates with the systolic BP. There is a trough, that is the diastolic pressure, and the mean arterial pressure is calculated from the area under the pressure curve, which is a more accurate way of doing it than the old diastolic plus 1/3 pulse pressure method. Okay. One thing to note is that your systolic and diastolic BPs can vary from a central pulse to a peripheral pulse, but the mean arterial pressure remains the same. Also, the reverse is true. Your systolic and diastolic pressures can remain constant, and as the pressure waveform changes and the arterial waveform changes, the area under the curve can change, and mean arterial blood pressure can also be different. Now, something regarding the timing of the arterial pulse and the ECG. Now, the arterial waveform is a systolic upstroke versus ECG's R wave. There is a delay of approximately 160 to 180 milliseconds. Now, you can see here. Okay. Now, why is that delay? Now, delay is that after the R wave, the depolarization wave has to spread through the left ventricle, and some isovolumetric contraction needs to take place, and then the aortic valves open, and then the aortic pressure wave needs to travel up the aorta and down the arm. This causes the delay. Now, a classical application of this knowledge is to try to manually set up the aortic balloon pump to a pressure trigger. Now, let us see the subcomponents of a aortic waveform. It consists of a systolic upstroke, systolic peak, systolic decline, a diacritic notch, diastolic runoff, and an end diastolic pressure. Now, let us concentrate on the systolic upstroke. Okay, this is the ventricular ejection. It is a peak aortic blood flow acceleration at the opening of the aortic valve. Now, obviously, the things that influence the aortic flow rate influences the component of this waveform. The slope of the waveform is directly related to changes in the LV pressure and the aortic valve competence. So, this slope is slurred in aortic stenosis. Now, some peak systolic pressure is the maximum pressure in the central arteries generated during the systolic ejection. The major contributions to this variable are the LV contraction central arterial compliance and the reflected pressure wave. Now, as the wave travels from the aorta down, you can see as the aortic wave travels from up to down, okay, what happens is that there is increase in the resistance in the vessels, and this causes some amount of reflected waves that come from the peripheries to the central. So you can see that as in the aorta, the reflected waves come a bit late. You can see there is an anacrotic notch that is created. As you travel down, the reflected waves merge more with the systolic part and comes in the early phase of systole. So we can see the waves in the terminal arterioles and arteries will be more peaked. Okay, and more peaked, and this anacrotic notch will also fuse into the main systolic peak. Now this phenomena in which the reflected waves go and they travel more and more distally, you will see as they travel more and more distally, these reflected waves are stacked up together, leading to rise in the systolic peak. Okay, this phenomena is known as distal systolic pulse amplification. Then there is systolic decline. Decline in the arterial pressure as the ventricular contraction comes to an end. The fall in pressure represents a period of time during which the efflux of the blood from the central arterial compartment is faster than the influx of the blood from the emptying left ventricles. This decline is even more rapid when there is a left ventricular outflow tract obstruction. Something about the dicrotic notch. So when the aortic valve closes, there is a sudden increase in the pressure as the aortic blood volume travels and transmitted to the peripheral circulation. In aorta, this notch is very sharp, which is known as incisura, which actually represents the aortic valve closure. Now, as we go more distally, this incisura is replaced by a dicrotic notch, which is generally a combination of different reflected waves that is accumulated over the period of time. Now we can see if we travel down, this is a wave pulse from a pressure transducer. As you travel from aorta down to the arterioles, you can see it has a peaked incisura to start with, and gradually it fades away and gives rise to a dicrotic notch that becomes more and more distal as you travel down, and what remains of the incisura and what we really call the dicrotic notch. Another point of important in dicrotic notches, it comes in the 1/3 part of the descending limb. The importance is that the pressure of the aortic compartment should be more than the pressure in the left ventricle. Then only the aortic valve closes, and you can see the dicrotic notch coming. Now what happens whenever there is a marked vasodilation, say in sepsis, okay, the aortic compartment pressure never crosses the pressure in the left ventricle. It will take more time to cross. So as it takes more time, the dicrotic notch will migrate downward. There is a downward shift in the dicrotic notch, which is characterized by this is a classical waveform in a sepsis, in which dicrotic waveform shifts downward from this to this area. Okay, so this is characterized by a low systolic pressure, low diastolic pressure, and a wild pulse pressure. So in disease conditions, say in aortic stenosis, what will happen? Now here the ventricle is struggling to squeeze the blood through the stenosed aortic valve. So the systolic upstroke will become very steep and slurred. Okay, the systolic peak is lowered, and the pulse pressure is also narrowed. In aortic regurgitation, instead of contracting isovolumetrically, pressure from the early contraction of the LV is transmitted directly to the aorta. So there is a sharp systolic upstroke. There is wide pulse pressure. The more incompetent the valve, the closer the systemic diastolic pressure will approach the LV end diastolic pressure, which is known as the Corrigan sign. The magnitude of the incisura, aortic incisura, diminishes with an increasing severity of the aortic insufficiency. In hypertrophic obstructive cardiomyopathy, there is a bisvariance kind of picture in which there is a sudden mid-systolic pressure drop, which leads to a bifid appearance of the systolic peak. Okay, this is due to the LVOT collapsing on itself, and the systolic flow is seized. Now, in severe sepsis, we already discussed that as there will be a peripheral vasodilatation, the dicrotic notch will come down. There is a delayed dicrotic notch that goes down. Now, as in these patients, you start the vasopressor therapy, you see the dicrotic notch appearing, and typically this kind of peaked pressure with a dicrotic notch appearing. As we are lowering down the vasopressors again, we see again the migration of dicrotic notch happening downwards and shifting downwards. This is classical in severe sepsis that we can see in day-to-day practice. Now, diastolic runoff and the influence of the arterial reservoir pressure. Now, the diastolic runoff is the drop in the pressure which occurs after the aortic valve has closed. Now, pressure does not drop suddenly due to the reservoir effect of the pumping of the blood in the elastic tube. Now, this elastic recoil contributes around 40% in the systolic, in the stroke volume. So we can see that generally aortic pulse will be a mix of three waves. There is a forward traveling wave, there is a reflected backward wave, and there is an arterial reservoir pressure. Okay. So how do we differentiate? In young patients, the arteries are more compliant. So this reservoir there will be a less reservoir pressure that will lead to a less systolic pressure. Okay. Similarly, in old patients, the arteries will be less compliant, so they cannot hold the blood. There will be pressure changes will be very rapid. So we will see the reservoir pressure will be more. So that will add to the systolic peak, and there will be increased systolic pressure. Now, end diastolic pressure, this is the pressure exerted by the vascular tree back upon the aortic valve. Hardened and non-compliant vessels will cause this pressure to be raised. And soft vasoplegic vessels of a septic patient will offer little resistance, and the diastolic pressure will be lower. Pulse pressure, a very widened pulse pressure suggests aortic regurgitation. A very narrow pulse pressure suggests a cardiac tamponade or any other sort of low cardiac output state. Now, there is another phenomena which is known as pressure wave reflections. Now, these are small, minute combination of waves that you see downstream or in the downstream or the dicrotic side of the aortic pulse. These are multiple wave which reflects a significant small vessel disease, something a patient like SLE coming to you. You might see a small multiple waves. These also represents a significant flow abnormalities. This can also happen in vasoconstriction that happens due to severe hypovolemia as well. Now, some physiological concepts and their clinical derivations, basically. So we'll go through the ventricular vascular coupling, something about the heart-lung interactions, and pulse contour analysis. These two topics generally will be discussed in the future, in the upcoming lectures. So I'll be very short and precise on this. So what is this ventricular vascular coupling? So as we know and understand the concept of how the wave is formed and how it is transmitted, what is the interaction between the heart and the wave, and what are the things that we can derive from that? So arterial waveform is produced by dynamic interactions between the volume of the blood ejected by the heart during each beat, speed with which this volume is ejected, and the ability of the vascular tree to distend and accommodate this ejected volume. Now we can also see there is a time lag between the flow peak and the pressure peak. This is due to the dynamic interaction between the stroke volume and the vascular wall. So you can see the aortic pressure traveling faster and the aortic flow preceding it. Now, there are two broad components of the waveform. There is a steady component, always remember there is a steady component, that is the map, and there is a pulsatile component that depends upon the stroke volume, vascular capacitance, peripheral vascular resistance, and the heart rate. So the systolic pressure is the maximum pressure recorded and is influenced by stroke volume and the vascular capacitance that measures the stiffness and distensibility of the arteries. Now, the diastolic pressure depends on ability of proximal arteries to recoil and continue to squeeze the blood forward against the resistance offered by the peripheral vascular beds. Okay, so if you combine this, as we know that, okay, the arteries in the elderly are less compliant, so they will have a higher systolic pressure and lower diastolic pressure. In neonates, they have a more compliant arterial system. You have a lower systolic pressure and a higher diastolic pressure. Now, in heart-lung interactions, there are changes in the arterial pressure waveforms in response to intrathoracic pressure fluctuations associated with mechanical ventilation. Now, this is used to assess the adequacy of ventricular filling and fluid responsiveness. Now, mechanical ventilation results in a cyclical increase, that is during inspiration, and decrease during expiration of the intrathoracic pressures, and these pressure fluctuation in turn will alter the diastolic filling of the right and the left ventricles. Now, intrathoracic pressure during inspiration will squeeze the pulmonary capillaries, that will lead to more flow into the LA, that will lead to increase in the LV systolic stroke volume, and that will increase the arterial pulse pressure. Similarly, intrathoracic pressure during inspiration will lead to reduced venous return to the right ventricle, leads to decrease in the right ventricular stroke volume, and there will be a gradual decrease in the left ventricular stroke volume as well, and consequent arterial pulse pressure. So there is a dynamic interplay between the intrathoracic pressure fluctuations and the LV output and the pulse pressure. Now this effect is amplified in hypovolemia. And there is an amplified arterial pressure wave fluctuations and exaggerated swing of the arterial pressure wave. In addition, there will be a beat-to-beat variation of the systolic of the stroke volume, which is known as pulse PPV, or the pulse pressure variation. Now, this swing is closely linked to the intrathoracic pressure fluctuations. That itself also is dependent on the tidal volume, inspiratory pressures, and the PEEP. So, in severe, point to remember is that in severe ARDS patients, in which the lungs are less compliant and there is a low tidal volume, intra-alveolar pressure fluctuations gets poorly transmitted to the intrapleural compartment. So these swings that we talk about are masked in the ARDS patients. So these methods are not applicable in patients who have severe ARDS. So we can see this is like typical pulsus paradoxes that we see, in which as patient is spontaneously breathing, as there is a negative pressure in the intrathoracic pressure, the blood gets sucked back into the aorta during the inspiration, and there is an overall downward swing of the arterial pressure from the baseline. Okay, this effect is exaggerated in patients with cardiac tamponade and restrictive pericarditis. Now, similarly, when the patient is on a ventilator, is on a mechanical ventilator, on a controlled ventilation, you can see the reverse thing happening. Some people call it a reverse pulsus paradoxus. What happens is that there is an upswing during inspiration, and there is a downswing during expiration. Now, when hypovolemic condition will be there, these fluctuations will be very marked, what we call as exaggerated swings. Okay, and similarly, we will also see beat-to-beat variation in the changes in the pulse pressure as well. Now, with this SPV systolic pressure variation and pulse pressure variation, with SP max, SP min, and with the PMAP, PP max and PP min, we can calculate the SPV and PPV, and that gives us an index of how much the patient is fluid responsive and how to manage the patient, how to fluid manage this patient. So now increased respiratory PPV will happen in inadequate right heart filling, that is hypovolemia and vasodilated shocks, excessive right heart afterload in cases of acute severe asthma, tension pneumothorax, and massive pulmonary embolism, decreased right ventricular compliance in cases of cardiac tamponade, RV failure, LV failure with LV dilatation. Now, pulse contour, the size of the pulsatile component of the arterial pressure waveform, either the pulse pressure or the area under the systolic pressure waveform, that is ASIS, okay, are intimately linked to the stroke volume, vascular, and the vascular compliance. Now, it is feasible to measure cardiac output directly using an independent method such as the pulmonary artery thermodilution method. It then becomes possible to establish the mathematical relationship between the pulse pressure, ASIS, and to independently measure the stroke volume and therefore the cardiac output. Now, this approach of making an indirect estimate of cardiac output using these derived parameters from a high fidelity arterial trace is commonly referred to as pulse contour analysis. So this will be discussed in the future. You have with the pulse application of the pulse contour analysis, there can be invasive, minimally invasive, and non-invasive, calibrated and uncalibrated systems. The most common PICO, LITCO are most commonly used in the clinical practice. We'll discuss this in the future presentations. Now, as we get over the physiological part, let us concentrate on the physics of the invasive blood pressure monitoring. Now, the basic principle of invasive blood pressure monitoring, it consists of a column of fluid directly connecting the arterial system to a pressure transducer. Now, this pressure waveform of the arterial pulse is transmitted via the column of fluid. A pressure transducer converts this mechanical energy into electrical energy, and it's processed and amplified and is converted into a visual signal and is displayed on the monitor. Now, what are the components? Definitely there is a intra-arterial cannula, then there is a fluid-filled tubing, there are three-way taps, flush systems, okay, and then there is a signal processor and amplifier and a display unit. Now transducer, what is a transducer? A transducer is any device that converts energy from one form into another. Now pressure transducers are used in IABP systems. The arterial pulse pressure is transmitted via the column of fluid in the tubing to a flexible diaphragm, displacing it. Now this displacement is measured by a strain gauge. Now what happens, this strain gauge is connected with a silicon wire, and that has as we stretch this wire, the resistance increases. Now what we do, now this resistance is calculated by the Wheatstone bridge circuit. Now what is the Wheatstone bridge circuit? It consists of various known resistance and a unknown resistor. So what happens, R1, R2, R3 and Rx. Rx is the unknown resistance. Okay. So now as the stress gauge is stretched, we see the resistance of the stretch gauge increasing. That represents the Rx. Now R2 by R1 should equal R3 by Rx, and the bridge should be balanced, and no current should be flowing through this galvanometer. So as we balance it out by applying this algorithm, we can calculate the resistance, and that resistance can be represented, and algorithm can be worked out, and it can be represented in the monitor in the form of a pressure wave. So now coming to the waves, what are the waves that we see and how it is formed? So what is a sine wave? A wave is a disturbance that travels through a medium transferring energy. One of the simplest waveforms is a sine wave. These may be thought to as a path of a point traveling around a circle at a constant speed and are defined by function of y is equal to sine x. Now the amplitude is their maximum displacement. Frequency is the number of cycles per second. Wavelength is the 2 points which have the same value and their phase. Now what is Fourier analysis? What do we do? The arterial waveform is clearly, it's not a simple waveform. Basically it's a combination of various components of various sine waves combined together. Now the arterial wave consists of a fundamental wave, that is the pulse rate, and a series of harmonic waves. These harmonic waves are multiples of the fundamental wave. Okay. Now you combine these harmonics together to get the original wave. So here you can see there are two sine waves. You can combine them together to form a more complex wave. Now the process of analyzing a complex waveform in terms of its constituent sine waves is called Fourier analysis. In the IABP system, the complex waveform, generally whenever a complex waveform is coming into a IABP system, what it does, it breaks it down to very simple sine waves. Now these sines, as it is broken down into sine waves, it divides it into a fundamental wave, and there is a harmonic wave. Generally 8 to 10 harmonic waves are combined together. It is reconstructed, and you see a arterial waveform. That is a function of that transducer, and that's what it does basically. As it gets into, and this is processed in the algorithm. And as the algorithm is processed, you see a combination of all these harmonics coming together and forming the arterial waveform. So IABP system must be able to transmit and detect high frequency components of the arterial waveform. So it should be at least have a 24 Hertz frequency, okay, in order to represent the arterial pressure wave precisely. Okay. So what is natural frequency and resonance? So all materials have a frequency at which they oscillate freely. Now this is called their natural frequency. Now when a force with a similar frequency is applied, which is close to the natural frequency, what will happen? It tends to oscillate more maximum and reaches a maximum amplitude. This phenomena is known as resonance. If the natural frequency of an intra-arterial blood pressure measuring system lies close to the frequencies of the sine wave components of the arterial pulse components, what happens is that the system will resonate and produce excessive amplification and signal distortion. Now in this amplitude versus frequency, you can see, now this is as you oscillate the diaphragm of the transducer more and more, and as you reach the resonant frequency, you see the amplitude increasing the max. After which, if you increase the resonance also, frequency also, the amplitude doesn't increase. In fact, it comes down. So this is the resonant frequency of that particular transducer system or that particular diaphragm. Now, it is thus imperative that all the components of an intra-arterial monitoring system have a very high natural frequency, at least 8 to 10 times higher than the fundamental frequency of the arterial waveform. So for the system to remain accurate, say for a heart rate of around 180, the natural frequency must be at least 180 into 10 by 60 is equal to at least around 30 Hertz. For a fluid-filled system, the resonant frequency can be calculated with the following formula, in which R represents the radius of the tubing, P is the density of the fluid, L is the length of the tubing, and del P by del V is the elastance of the system. So thus, to obtain the highest possible natural frequency in an intra-arterial blood pressure monitoring, we require a shorter, wider, stiffer cannula and tubing with a lower density of fluid. Now damping. What is damping? Anything that reduces energy in an oscillating system will reduce the amplitude of the oscillation. This is termed as damping. Okay, so whenever the frequencies, number of frequencies that are coming together, when we combine it together and we put a damping, it takes care of that excessive frequencies that are there, and it modulates it and helps in producing a proper arterial waveform. So some degree of damping is required in all the systems. Okay, this is known as critical damping, but if excessive, that is over damping, or insufficient, under damping, the output will be adversely affected. In an IBP measuring system, most damping is from the friction in the fluid pathways. There are, however, a number of other factors which will cause over damping, which includes excessive three-way taps, bubbles in the clots in the system, if there is a vasospasm, narrow, long or compliant tubings, kinks in the cannula or the tubings. Now, an overdamped IABP system, say example, this is an overdamped IABP system. What happens? Say the damping coefficient is more than 1. In this system will not oscillate freely, and the details such as the dicrotic notch is gone from this system. So it tends to underread the systolic BP and overread the diastolic BP. Okay. Similarly, in an underdamped system with a damping coefficient of less than 0.7, this system will be quick to respond, but will tend to overread the SBP and underread the diastolic BP. Now, in an optimally damped system, the ideal is around 0.7. This provides the balance between the speed of response and the accuracy. Now, how do we test this response? We do a square wave test. What do we do? So this is the normal, whenever you see in the monitor this is the normal arterial waveform with a good dicrotic notch. This suggests that this is a critically damped and optimally damped arterial wave. How do you test it? We do a fast flush test. There is a square wave that is formed, and when we do a fast flush and we release the fast flush, we see there is a oscillation. There are no more than 2 oscillations that happen, 2 oscillation waves that happen. Now what we do is, we can see the amplitude of these 2 oscillating waveforms, A1 by A2. This is amplitude ratio. These ratio is pitted in a graph which tells us about the damping coefficient of that system. Now, how do we see an underdamped system? An underdamped system, you will see many multiple artifacts that run across the waveform. Okay. Now, when you do a fast flush and release, you will say there will be a multiple oscillations, more than two oscillations and multiple. This represents an underdamped arterial system. What is an overdamped system? You can see the waveform. There is a loss of dicrotic notch, and when we do a fast flush, there is no oscillating waves that come. So this is how you test for an overdamped, underdamped system at the bedside. So this is a model in which this shows the interaction between the damping coefficient and the natural frequency. Now in the wave A, you see it's an underdamped wave. It has multiple small artifacts. As you increase the damping coefficient, you see the artifacts getting ironed out, and C, which is the critical damping, you can see this is the ideal waveform that you get. As you increase the coefficient more, you see the waveforms getting smoothened out. So the optimal critical damping is the accurate pressure, and even though it is low, it represents all the different components in a very legible manner. So this graph is about the interaction between the damping coefficient and the natural frequency. Catheter tubing transducer system fall into one of the 5 categories. Now, first is the unacceptable category. Any damping system with less than 7 Hertz definitely is unacceptable to us. Okay. Any damping coefficient that crosses more than 8 becomes a overdamped. Any damping coefficient that is less than 0.4 or 0.5 becomes a underdamped system. There is an adequate dynamic response range. Anything that lies between that is an optimal dynamic response. Leveling and zeroing. So for a pressure transducer to read accurately, atmospheric pressure must be discounted from the pressure measurement. This is done by exposing the transducer to the atmospheric pressure and calibrating the pressure reading to 0. Now leveling is the pressure transducer must be set at appropriate level in relation to the patient. The level is taken at generally the patient's heart at the 4th intercostal space in the mid-axillary line. So the take-home messages from this presentation will be that we should be, whatever simple techniques that we have, the arterial, definitely it's one of the most useful waveform that you can have in your monitor, and make it a habit that daily having a look not at just the pressures, and also studying the waveform very immaculately, because the waveform can give you much more information than whatever you can see in the patient. Okay, studying the different waveforms, the different limbs, okay, and also compensating. If we know about the underdamping, overdamping, we can definitely apply our fast flush and really adjust our systems so that we get an optimal arterial waveform trace. Okay, thank you. Yeah.
Wheatstone bridge principle.
Huh.
Go through that once again.
Yeah. So what happens is that, see, in a transducer, the transducer is, the diaphragm is connected to a pressure gauge. Now that pressure gauge, the pressure gauge is a silicon wire. Now if the pressure is increasing in that diaphragm, that is transmitted, that is the mechanical pressure. What it does, it stretches. Now this wire, as it stretches, the resistance increases. Now that resistance increase is this Rx. So, and as the Rx is there, this is a Wheatstone bridge, that is a balanced bridge. Whenever there is a change in the Rx or the resistance, what you will see is that this Rx can be calculated, change in the resistance. This change in the resistance is what transduces from the mechanical to the electrical side. And this definitely can be further, with the algorithm, can be assayed, and the waveform is formed with the constituent waves. So this basically is changing of that mechanical to the electrical energy. This is the resistance of that wire that helps you to determine that resistance, unknown resistance. Okay, this changes in the transducer as the pressure changes.